record to the cloud. Otherwise, they're going to my phone.
Okay. Thank you, Dr. O, for being my patient today. All right, so I'm going to do a more interactive lecture, kind of like what you'll do for your exam. We are going to have the lecture on this side of the screen and the rubric on this side of the screen. I'm going to try my best to do it like you have to do it to get your full points. All right. Knock. Hi there. My name is Donna Stachowicz. I'm a nurse practitioner, and I'm going to be doing a head, eye, ear, nose, throat exam on you today. Do I have your consent to video this exam and upload it to YouTube so that my professor at USU? Awesome. Thank you so much. If at any time during this exam I make you uncomfortable or something hurts someone in your ear, please tell me and I will adjust my technique, okay? All right, I'm going to start out by just visually correcting Dr. O's head, and I'm looking for symmetry. I'm looking for symmetry of the face as well to make sure the eyes, the outer canthus lines up with the ears, make sure her mouth, nose, everything is symmetrical. And after I inspect, I'm going to start to palpate. I'm looking for hair distribution and texture. And if it's coarse or if it's fine, if there's any loss of hair. I'm also feeling the scalp and the skull for any depressions, any hematomas, any contusions, any lesions, any signs of psoriasis or dandruff or plaque. And then after I palpate and look at the head, I'm going to go ahead and move right on to the eyes. And so we're going to click on the eyes here. And for my eyes, I like to start with my visual acuity. I always do the ophthalmoscope last because that eye, this blinds the eyes, it's so bright. So I'm going to check the visual acuity. Now, Professor White demoed the visual acuity with a 14-inch for the near vision, okay? And I'm going to demonstrate for far vision. So there's actually presbyopia, myopia, and hyperopia. The way I remember myopia is my short can't. Myopia is short-sightedness. It means this patient can read things up close, but far away is blurry. Hyperopia is the opposite. It means you can see things far away, but the near is blurry. Presbyopia is actually from aging, and it's usually loss of near vision. Okay, so this is the wrong Snellen chart. I'm going to get my pocket Snellen. Okay, thank you. And there are Snellen charts at 10 feet and 20 feet that you'll have in clinic. But my current job as an NP is home health for San Ysidro. I go out and do patient exams, and I use this truly in my job every day I go to clinic and on every patient. So 6 feet away is about, average human man in what country you're in, or you could walk about 6 feet. And you have it, it's ideal to be right in front of the patient, not at an angle. It's hard for me because we have students there. I'll show you for me. Thank you. We always assess right and left and then together. Did Professor White already explain why? Because I missed that part. Why do we do right, left, and then together? Or why do we do all three? Right. Some students in the past used to check both only. And when you document, you can't just document 2020 OU. Because if you document 2020 OU, that implies that you only check bilaterally, but you have to check individually, right eye and left eye. Let me tell you why. Truly in life, my left eye has a better prescription than my right. This eye is stronger. It's like 1.5 and this one's 2.5. When you have both eyes open, your brain automatically defaults to the better eye. So if I only tested Dr. O bilaterally, I'm going to get a good number, and I might have entirely missed a vision problem in one of her eyes. So go ahead and cover your left eye for me, please. Okay, and then I'm about 6 feet away. Could you please try to read the lowest line you can without see? Great. Can we try one more? Okay, next. Okay. So she actually got more than 50% right. You can give them the lines if they get more than half correct. If they miss more than half, you don't. You give them the next higher line, okay? And then she'll switch eyes and do that over. We don't need to make her do it over. But one tip I like to do is I like to have them read it backwards the next time. Otherwise, they start to memorize the text. Yeah. And then after you do right eye, left eye, then you do both eyes open. In your documentation for your course and in real life, you've got to document each eye. And that's how it is in my EMR. OS, ocular sinister, left hand. Back in the old days, they thought it was able to be left-handed, so ocular sinister. OS, OD, ocular dominant, and then OU, unified or unity. OU, both. Okay, so document each finding. So that's your visual acuity. I'm also assessing in general the external eye. I'm looking at the lids. I'm looking for ptosis. This P is silent, signs for drooping. I'm looking for any crusting of the lid margins. I already sanitized my hands. I'm going to cool down the lower lid and assess for conjunctiva and hoping they're pink and not red and inflamed. Also, we don't want them to be pale, which could be a sign of anemia, right? I'm looking at the sclera and I'm looking at the cornea and looking at the eyes now. I can move on and use my pen light and I can check for reaction of the pupils. I'm going to check two things. I'm going to check consensual and I'm going to check direct reaction. Did we explain that with Professor White? Okay, direct, you have to do it twice. So it's direct first. I'm only looking at her right side with my eyes and I see that it constricts. To check consensual, I'm going to shine the light again to the right, but I will be looking at her left pupil to make sure that it reacts consensually. Then I'm going to do the same thing on the other eye. I'm going to shine it to the left. I'm looking at only left and it constricts. And now I'm looking at the right to make sure it constricts consensually. All right. So that's your pupillary size and reaction. The size is on your pen light. And we're going to talk about that in the last lecture. With the extraocular movements, you already talked about them. You have abducens, which is your lateral, and your trochlear downward medial, and everything else is ocular motor. There's more than one way to skin a cat. So in your video, some people prefer all of it. Some people like to make an X. X marks the spot. Don't forget to cross through the X, and then you can even do vertically too. Or some people like to do an H. Okay? Because guess what? They all get the job done, right? Either way, you need to say out loud that you're checking your cranial nerves and which one you did, and then check them. The other thing you're going to check for is convergence. Can you converge on an object? Bringing her eyes close to the object and close to your nose. And then finally, accommodation. Accommodation is a little bit harder to see, but basically, you look at the patient's eyes really closely and you say, can you put this on the tip of the pen? And then you say, okay, now look at something way far away on the wall. And you watch the pupils as they let in more light or constrict to look for the, let in more light to see something further away. So that's accommodation, the pupils changing to accommodate for the distance, okay? So we got our pearla and we looked at our external structures and our sclera, our cornea from the side, just a brief, like we didn't do in depth. If there were any gross corneal abrasions, I might see that. If there was any signs of infection, I can see that. And we already did our extraocular movements and our visual acuity. And so I saved this for last. As Professor White said, it's her right eye to my right eye. And you always have safety in mind, and you always want to find the red reflex first, because you won't be able to find the object anything without getting the red reflex. And actually, in your video, you can verbalize. In real life, you dim the lights. Okay? In real life, this exam takes some practice. It's best to do it with a dilated eye. You can see a whole lot more. And there's a lot of fancy machines out there. We have one of them. I'll show you a pen where you can do a pan optic and see everything at once. So what I'd like to do now is break real quick and show you whiteboard what you're kind of looking for. Okay. All right. So when you first look at the red reflex, you're seeing the whole back of the eye, that's the retina. Okay. And in the retina, within the retina, is the optic disc. All right. The margins should be sharp. It shouldn't be all blurry and obscured. Within the optic disc, even brighter than the disc is the cup. So this is orange, this is a lighter orange, and this is the brightest, brightest, brightest. The white, really. And it's hard to find it. A lot of students, unless your instructor explains it to you, or unless you've done a lot of reading, when you look at her eye, you're not going to see this, guys. You're not. What you're going to see is a tiny little picture of it. So this is how it looks in the textbook for a panoptic scope. But when you see it with your scope, this scope, you don't see this. You see literally a teeny tiny little window. And when if the patient moves, it's hard to find. Okay, it takes some practice and concentration, and you have to really hone in on a vessel, because vessels, veins or arteries. Remember, she talked about veins being twice as thick. It's kind of counterintuitive, but that's the truth in the eye. These are like arrows. So if you find a vessel, it's like an arrow pointing you to the disc. So if you find a vessel, you're golden, because you just follow that vessel and bring to a branch and think, okay, I'm looking for the disc. What you're looking for is that sharp margin, and nice and not obscured, because as Professor White said, if it's obscured, if it's a blurry margin, it could be happy with you. Or long-standing hypertension. Okay. Other things you're looking for are things called pop and blue spots. All right. Signs for hypertension, or you have AV nicking, okay, from hypertension. The other thing you want to make sure you don't have cupping. I feel like my picture's got, we need to zoom out, but this is cupping. So normally, oh, thank you. In a human, the cup to disc ratio is anywhere from about 0.2 to 0.6, where humans are all different. 0.3 is average. 0.2 to 0.6 is normal. The ratio is the cup. Remember how I drew on that picture, the cup and then the disc? Should be about 1 to 3 on average. If it's too big, that could be a sign of cupping from glaucoma. Okay? And these things are things that you need to refer if you see it. A lot of times you won't even do this. If you have a diabetic patient, you will be referring at least yearly to ophthalmology, and perhaps as often as 3 to 6 months if their diabetes is really bad and they have complications. Okay, so that's what we're looking for in our exam today. And you guys will have not only time upstairs to practice with this, but you'll have an hour lecture on scope, because we realize, no lecture, an hour hands-on, because we realize this is hard for you, and we have some really cool tools to show you so that you can get practice, like on a little fake eye. So now we'll go through the motions. This is how you do it in your exam. You say, I'm going to dim the light, I'm going to check the retina, I'm going to check the optic disc doctor. Okay, I found the red eye reflex. I'm going to hone in at a 15-degree angle. I'm going to find a vessel. I'm going to follow the vessel medially towards the nose, and I'm going to see the optic disc and the cup. The cup concentration is about 1 to 3. No signs of AV nicking. Our margins of the disc are sharp, and everything looks healthy. Okay, and then you go ahead to the other side, and you do your left eye, you do your left eye, and then you say, I'm going to turn back the lights back on now. Good. Okay, so if you could scroll down, please, Professor White, on my rubric here. I want to make sure I covered all the stuff with I didn't. I missed something. Oh, shame on me. Visual fields by confrontation. Did Professor White already demo that? Okay, so yes? Yeah. Oh, okay. So just make sure you do that. You have her cover her eye, or you can even be the examiner. You can even close your eye like this. Because and remember, this test assumes the examiner has healthy peripheral vision. If yours isn't good, you could get some false results. Right?
But based on the video that was put on,
Right.
The confrontation they did was put the hands backward and bring it up, and then she did one.
There's
and then,
several different ways. Right.
Okay,
So Jessica Nishikawa has great videos, but you are still responsible for what's in the rubric, and that's when you use your textbook. It'll be a minor point, like a half a point or something.
so is the way she did it not correct?
Yes and no. Okay, so if you Google, if you YouTube video and you look at an ophthalmologist answer, they will say, no, that's not technically correct. No, you should actually look at one eye at a time, because imagine if both your eyes are open. If you're doing this, your good eye could accommodate for that bad eye. You really should be testing one at a time.
So she did one.
No, I don't know if she did. I think she was just doing this and this. But that's not exactly right. Trust me, if you look at your base textbook, it has the right one. So yeah, just
I have to do it.
you don't have to do it again. It'll just be minor points. If you want 100, if you're like, I've got to get 100, it'll be a minor point. And it's a good lesson learning example to, wait until you've had the lecture first, right?
When you have somebody that for a class with a contact or something like that, so you're assuming that this is not corrected.
Oh, okay. For visual acuity, I mean, that's you can document that correctly. Okay. I want to see what the corrected is because I want to see if they need new glasses. Okay. For visual field confrontation, that's checking their peripheral vision. That shouldn't really change if they have glasses. I would allow them to wear them. That you're looking for gross abnormalities. We don't have the Amsler grid to really detect macular degeneration to diagnose it. We can screen with this gross exam and then refer if there's something grossly abnormal. Okay, yes.
Did you just the description or ratio?
0.2 to 0.6 is the range of normal. 1 to 3 or 0.3 is average. Yeah, and you don't want it to be too big because that's called cupping and it's a pretty kind of glaucoma. So we got everything with the eyes, and I forgot to mention nystagmus. When I did my extraocular movement, I was looking for nystagmus. What that is little beats of the eye, little motions of the pupil, not of the whole eyeball, but the pupil. Beep, 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 beep. And when you document, you need to document, is it lateral or is it a vertical nystagmus? Okay, so or horizontal or lateral, and if it's at rest or not. Some people even have it at rest, or it could just be with extraocular movements. If they don't have it, for your note, just write nystagmus. Okay, and then go ahead and scroll down. With the cornea and the lens, on the reverse, scroll down, please. The cornea and the lens, what you're looking for is corneal abrasion. Sometimes they're obvious and you can actually see it. Sometimes they're not. And the history for that would be like an itchy eye, something painful, and you can do what's called a fluorescein stain in your clinic, where you actually stain the eye and the eye uptakes the dye, and then you have a Woods lamp, which is like UV light or blue light, and it makes the lesion show up. All the ER nurses have done that for sure. And the lens, you're looking at the lens for opacities, which could be a sign of cataracts, right? It should be nice and clear, the pupil nice and black. And that's an example right there of a cataract. And then we have examples of the dyed corneal abrasion. There's one you can actually see with your naked eye, and this is what it would look like on the Woods lamp. It's really fun and cool to see. And then, so next you can go to nose or you can go to ears. If you go to the nose, you want to inspect first. I'm looking at the symmetry, make sure there's not gross deviation or anything wrong. And then I'm going to palpate for sinuses, for frontal sinuses, and for maxillary sinuses. Remember, just there's like a test question, maybe hint, hint. Are the other sinuses palpable? Can you palpate them? Right? The sphenoid and ethmoid sinus, no. You can only palpate the maxillary frontal sinus. Okay, so you palpate that. I'm going to check nasal patency. Breathe through this nostril, please. And then this one. Okay, nice and patent both sides. I could do my sense of smell too. Have her close her eyes. We'll check one nostril at a time. What do you smell? Good. It'd be great if I had another substance, but I don't. There you go. Coffee. If you have two substances, great. Vanilla, coffee, peppermint, whatever you want. I know, right? And then you're going to check the nose internal structures too. Get out my. Oh, I left it in the back. Right back there. I'm going to look at her nose with the same otoscope that I have, but I'm going to put a nice clean spectrum on it. And then I'll change out the spectrum when I go into her ear. I'm the form one. Oh, I mean, okay, if there's anything I do that makes you comfortable, let me know. Have the patient tilt their head up a little bit. I can rest my hands right here on the chin and open up the nose a little bit. Okay. Oh yeah, that's important there. That's right. Okay, so what you're looking for is nice pinkish mucosa, nice and healthy pink. If it's very red, that's a sign of acute inflammation, right? Allergies. It could be allergies. It could be a head cold, a sinusitis even. But if it's very pale or bluish or boggy, that could be long-standing allergies. Okay, so acute allergies or acute problems usually bright red. You could look for the turbinates, and you might even see polyps, or if in a little kid, or bodies possibly. Okay, yeah. So I'm going to go ahead and change my spectrum mask here. And I'm going to get a clean one here. And I'm going to move on to the ears. All right, first of all, I'm going to inspect first, looking at the ears externally, looking for any signs of drainage, any redness, the symmetry, placement of the ears. And then I'm going to, after inspect, I'm going to palpate. I'm going to do the tongue test for otitis externa. I'm going to pull down on that pinna on each ear. And I'm also going to push the tragus, okay? If someone has acute otitis externa, AKA swimmer's ear, that can be pretty painful, okay? And so don't press too hard, just be gentle if someone comes in with an earache and they swim. It happens a lot in kids, and it's more common in the summer. All right, after I inspect and then I palpate, there's a few ways to hold this, and we'll practice upstairs, but you can do upside down and use these fingers to support against the head of the patient so that you don't push it in further, okay? Or you can use like the hammer method and put your fingers down there. I like this way. When you have in clinic, you're always going to have a wire attached. It's a little bit difficult, takes some practice. For adults, you pull up and back. For kids, you pull down, okay? Down and back. So I'm going to go up and back. I'm going to position myself. And if I make you uncomfortable, if I do cheap, tell me right away, okay? And then look inside. There's some clean, beautiful TM. All right, what I'm looking for, what you need to verbalize to get your points is that I saw the TM shiny and curly gray and no bulging or redness. I saw the cone of light at 5 o'clock, and I saw the umbo, okay, or whatever landmarks you saw, I could say, the shorthand process of analysis in the umbo. That's what you usually see. And the cone of light, by the way, I have some pictures on it over here. And see right there, that is the cone of light on the right side.
Can you repeat again what normal is for
Sure,
everything?
sure. It's on the rubric. It's on the rubric. So if you scroll down, closer right on the rubric side, it's all there.
You just need to say what normal is, right?
Tympanic membrane. It's all on your textbook. Okay. Pearly gray, shiny pearly gray, non-bulging. You can see the cone of light. You can see the umbo in the short process of analysis, and no erythema. No bulging, no fluid, signs of fluid or possible repair. You don't have to say all of that, but just say what you see. Normal, healthy, TM, cone of light. Now, the way I remember the cone of light on the right is at 5 o'clock is I like to leave right at 5, right? I like to leave work right at 5. And on the left, so on the left it's 7. So right at 5, left at 7. I misspoke earlier. I'll confuse my right and left. So then you go over and do the other side. And the other thing you need to do with the ears, and I usually do this before, I usually check hearing before, but I forgot today, is you already learned the whisper test. As long as you include the ears, stand behind, so the person can't read your lips. It's preferably a 2-syllable word, and preferably a different word on the other side. You can even do 3 numbers, like 1, 2, 3, and then ABC or something on the other side. And for your hearing, and then we already talked about the Weber and the Ryan test. And if you go back, I had it up earlier, Professor White, I'm so sorry. I had a chart. Yeah, if you want to zoom in on that, it has this little chart that you can help remember what is conductive and what is sensory neurohearing loss. Okay? So it's on the presentation for you. One of the things that I like to mention to save you time is a concept that you need to understand about air conduction and bone conduction. Okay, so when you put this, everyone can try this on themselves too, if you have it readily available. And as the time progresses, the sound gets less and less. Okay, and then when you can no longer hear it, you put it here. If you can still hear it, you can stop right there. You don't have to use your wristwatch at all in time anymore. Okay, because what does the law of physics say? If you strike this over time, what's it going to do? Less and less and less. So it's doing that less and less and less and less and I can no longer hear it. Can I hear it? Yes. All right, I'm done with the test, because guess what? If I can still hear it after all that time has passed in front of my ear, that means my ear conduction, this is your ear in front of your ear, right? That was longer than the bone conduction, okay? Does everyone understand that? You strike it on your elbow or your palm, the bony part of your hand, a desk, a knee, whatever you have, and put it on your masculine process, the bone right behind the ear. And I bet you someone will have some kind of conductive hearing loss. If someone has a ear infection or otosclerosis, a blockage of some sort, and then when it stops, as soon as it stops, you should, if you're a normal hearing, you should be able to still hear it when you put it here, okay? That is the normal finding. I had otosclerosis for years and had surgery in August, and I did not have air conduction longer than bone. I could only hear it here. When you put it here, I could hear it. Yeah, but that's you have to. And then, so with conductive hearing loss, it could be from ear infection, the blockage, or otosclerosis, something that's preventing the sound from being conducted from outside to the in. Okay, so you have preserved bone conduction in conductive hearing loss. In sensory neuro hearing loss, it's with the nerve actually being damaged, right? Like long exposure to sound, right? Not an infection, not an organic thing, but something with the actual nerve itself. And your bone conduction isn't going to be much better, okay? So we're done with the ears. So we need to make sure ears, hearing, internal, external. And then you're going to go on, oh yeah, I can show you these pictures too. So acute otitis media, and remember, everything looks different. So you see one picture in the textbook. This is not what all acute otitis medias look like, but in general, bulging TM, red, inflamed, and they usually have a report of pain. Okay, you might have drainage, you might not. That is an otitis externa. It usually looks really pale, and the tissues are sometimes so inflamed that you can barely get back here to look at the TM. You could have ruptured TM. Okay, you actually sometimes it's black looking like a hole. It's just a hole. And if you have a ruptured TM, you never want to put or prescribe any kind of otic drops, OTIC. Serous effusion, that's fluid in the ear. Sometimes after the infection's gone, you still have this accumulation of fluid, and sometimes the patient presents with just hearing loss or a stuffiness feeling, or sometimes air bubbles are popping, noises in their ear. And this is tympanosclerosis. You have some whiteness and scarring of the eardrum. And then you have the last picture of bullous laryngitis, which is blisters, really painful red bulging blisters on the tympanic membrane. Those are just some common ones. There's other things that are in your textbook that are not on this PowerPoint. So now we can go ahead and move on to the neck. I can start out just externally looking at her neck for symmetry, looking at her trachea. It appears, you know, to be symmetrical, and I can put her through range of motion. So I'm going to have her hyperextend. I'm going to reflex. I'm going to have her laterally rotate, and then laterally bend, and then focus. It's rotate and then lateral, right? So good range of motion. If your patient's old or if they've had neck trauma, you should be wary about doing that, especially the hyper extension. Don't do that if they're old arthritic or if they've had recent trauma. With the neck, you could also, I skipped now. We're on next, that's okay. We'll go back. With the neck, we're going to look at the lymph nodes and the thyroid, okay? So with the thyroid, you want to first visualize from the front. It's ideal if you have water for your patient, and just observe the patient while she swallows, he or she swallows, and look for if you see any obvious goiter, okay? And then you'll also do it from the back. When you go from the back, you're going to touch on the tip of your chin and follow that down to the first hard structure you feel. And everyone can do that on themselves. That's the thyroid cartilage. The next one down is the cricoid cartilage. And then after that, you have the first two rings of the trachea. And I'm going to put my fingers on either side of that. I'm going to press and see if I feel, if I can displace the thyroid gland one side and the other. And I'm going to actually kind of push back. It kind of hurts. And it's almost strangling, like, and then have her swallow. And I was kind of feeling if one hand was displaced more than the other or moved one more than the other. And that's for your thyroid assessment. It's helpful again if you have water irritation. She's a good trooper there with the dry throat swallowing. And so with the thyroid, I'm also in this area. I can go ahead and do the lymph nodes. And with the lymph nodes, you have to name them while you do your assessment. So you talk about your submental, submandibular. Use the fingertips, okay? Fingertips, submandibular, and then the tonsillar, okay? The posterior auricular, behind the ear. Pre-auricular, okay? And then your posterior cervical, I've heard it pronounced cervical also, behind the sternocleidomastoid. And then also the anterior cervical in front of the sternocleidomastoid. And then you have your supra above your clavicle, clavicular. And then you have to really get in deep to really feel them. And hopefully those are not inflamed. It could be a sign of cancer. And then your infraclavicular. And then also, don't forget behind your occipital. Okay? Now, lymph nodes can be inflamed for a variety of reasons. It could be as simple as a tonsillitis or a strep throat or a sinusitis. But if the lymph node is swollen and warm and not mobile, that's concerning. You want to refer and get further testing for that. It should be mobile and non-tender, okay, if there is a lymph node that you can feel. Definitely refer for anything clavicular, supraclavicular, and infraclavicular. With our HEENT, we don't want to skip our mouth. Mouth has a lot of little points that you have to say, like looking at the lips, making sure they're not cracked, making sure they're nice and moist, no chelosis and no herpetic lesions. Okay, and then you want to put your gloves on for this one, and you want to have your flashlight ready, pen light, and you want to have a tongue depressor for this one. And for this one in your video, you're going to do a lot of talking. Don't make the patient sit there, talk first and then examine and talk. So some of the things I'll be looking for her when she does open her mouth is that, I already talked about her lips. I'm going to look at the buccal mucosa, make sure there's no lesions or any tearing of the inner cheeks. Make sure I check her salivary glands by having her lift her tongue and looking at her salivary ducts. I'm going to check her dentition to see if she has any gross caries, dental caries that I can see, or a chipped teeth, or severe discoloration or missing teeth. I'm going to look at her tonsils, tonsillar pillars, and when I see the tonsils, I'm going to grade them, and we have a grading scale for the tonsils when we go into there. And if they're touching, that's grade 4, okay? 0 is barely there and don't even really see them. Grade 1, just coming out of the pillars barely. 2 are enlarged halfway. 3, they're at the uvula. Okay, and 4, like I said, is touching. That's really bad. The other thing you could look for, not too common, probably more in the ER, but peritonsillar abscess. When you could have one tonsil totally taking over one side. You could even have some deviation of the trachea. Sometimes you feel bad ones. So tonsils, you're looking at the pharynx, the posterior pharynx. You're looking at the palate, the top, the roof of the mouth, the hard and the soft palate. Often in strep throat, you might have palatal petechiae, the little broken blood vessels, the little dots. That's often a finding in strep. You're looking at your tongue, at the texture, the distribution of the papilla on the tongue, making sure there's no thrush for babies or candida or geographic tongue or leukoplakia, plaques on the tongue. Let's see, tongue, mucosa, lips, uvula, make sure it's midline. And, you're kind of having her say, and you can do the hypoglossal too to check her tongue back and forth. So go ahead and say for me. Her palate, go ahead, thank you. Palate with raises equally with the uvula midline, and also lift your tongue up for me. Let me see underneath that tongue. And for my mouth, I really get in there and inspect and sometimes palpate, because very important to do, especially on smokers or anyone who chews tobacco, anyone who uses those kind of products, because they're really at risk for mouth cancer, throat cancer, and I've caught that on exam. So you gotta be really careful. And then now I'm looking at her mucosa, like I said I would do earlier. Her gingiva, I forgot to mention gingiva. So the gums, you can check for anemia by looking at the gums too. Not only that, but the gum health. And Dr. O has beautiful teeth, by the way, and beautiful gums, very healthy. And everything's good and normal there. Yeah, and then the tongue, you can check to make sure that it has good strength, push against the tongue blade. You could also just have her push against her cheek to make sure, and we already checked, midline, stick it out. Yep, and a nice papilla, evenly distributed, no abnormalities there. So we'll go through our rubric and make sure I didn't miss anything that you guys need to learn.
Yes, question.
Yes, question.
Do we need to have gloves and a tongue blade, or just verbalize it? I would put my gloves on.
Okay, so when you're at home, I want to see you, practice. Get a spoon from your kitchen, or use the blunt end of a butter knife or something, soft blade, or whatever you have in your home. Wash your hands first. And if you don't want to put your hand in your mouth because you have gloves at home, tell me. I would look and look at both sides of the cheek, look around the tongue. Tell your instructor.
Better to just have some gloves.
If you have it, if you don't, you're not. I don't think any of us would take off points for that, but I know Dr. None of you have Garcia. Have you heard? So yeah, any questions on HEENT and faculty? I'd love you to speak up and offer input on HEENT and correct me if I'm making mistakes too. Okay, so what I need, thank you so much, appreciate it. Before you get out of your seats and it becomes chaotic, I need to please bring up